Um, what I think is interesting is about a third of these, when you hear a few of these stories, after a while you start to be like, I recognize this story. This story is familiar to me. And I think that's kind of the great teaching of neurology, old school neurology at least, or classic neurology, is the history is everything. So, and the data has now really confirmed a lot of our experience in that. Is about a third of these people will have this prodromal, nonspecific fever, upper respiratory or GI symptoms like any nonspecific viral illness. And that's when the story starts. And there'll then often be like subacute progression of their neurologic symptoms over weeks to months. I think a lot of times people consult me or I get questions based on a blood result or a CSF result or an imaging result. And often this is the key part of the story that no one's talked about or is missing. And it's very nonspecific, but it really does set a tone and help you, I think, separate from some other disorders. What's interesting is about a third of these happen prior to a known cancer, a third of them happen at some point during cancer, and a third of them happen at remission or as a sign of relapse of a prior cancer that was thought to be in remission. These disorders are really disabling. They dramatically increase cost of care, often the burden to caregivers. As with many neurologic illness, they affect functional status and cognition, shifting decision-making. So I think a lot of us really recognize how difficult these are for us, for patients and families to navigate. I think there's been a lot of enthusiasm because some of these disorders really respond very well to treatment. But unfortunately, I find myself reminding people that many of these disorders still do not. So there's still a lot of work to be done. That's kind of something when we get to treatment, I want to talk about and review a little further. Wernicke's encephalopathy and neurologic thiamine deficiency are much more common in cancer patients. Most cases in cancer patients are not associated with alcohol. And I think we are all taught to think about it as alcohol, but there's many, many, many causes of thiamine deficiency that are not related to alcohol. Cancer patients often have weight loss. They're under acute nutritional and metabolic stress. Other strong risk factors are people on dialysis like this patient, people with diabetes, even if it's well controlled, people with HIV, even well treated. Any cancer can be associated with it, but upper GI cancers and lymphomas are kind of strongly associated with it. So I would say whenever you're thinking paraneoplastic, to me, there's just a list of, wait, did I think of these mimics that are very treatable and are like, do not miss? And this is the top of my list whenever I'm thinking about paraneoplastic disorders is, could this be thiamine deficiency? And has it been treated? And if not, is there any reason not to treat? They often get worse in the setting of a metabolic stress, chemotherapy, an acute infection like this patient had. And a lot of times people just think of them as delirious, and they often are delirious, but then they miss the rest of the picture within that delirium. So this is like a very partial list of mimics of paraneoplastic disorders. I really like to emphasize the things that are treatable. Herpes encephalitis is another one. Non-convulsive status is much more common in cancer patients and very easy to miss. A myasthenic crisis, which I think is becoming more common with some of the immunotherapies that can provoke myasthenia. And then the other one is acute hormone deficiencies, especially pituitary apoplexy, which is not that rare in people with metastases. It's not that rare in people who've had any radiation to the head and neck region. And then there's a lot of chemotherapies and antibiotics that can cause acute deliriums. And these are all things that I've seen people think, oh, could this be paraneoplastic? So to me, the first question is, could this be a non-paraneoplastic treatable mimic? Because all of these things are as or more common in cancer patients than paraneoplastic disorders. So I really like to emphasize mimics, do not miss. You do not want to diagnose thiamine deficiency on an MRI. That's like, oh boy, that was a big miss already. So, and I think often the clue to a lot of these mimics is hyperacute onset. You don't get that longer, slower, subacute progression of symptoms. They didn't have a prodromal syndrome. So you really want to carefully review medications and events prior to acute symptom onset. And most of these people, they already have a known cancer. So to me too, when you already know someone has cancer, I'm like, they've probably been through treatments and surgeries and nutritional stress. So they're probably more likely to have some of these mimics than anything else. So now I like to kind of go on into the more standard part of the paraneoplastic talk. A lot of people separate these by antibodies. Many of the reviews are based on this. Did someone have a question? Maybe not. Maybe an accidental unmute. I like these reviews, but the problem with a lot of the reviews that emphasize the antibody is most of us are not confronted with a patient when it's like, oh, this patient has this antibody. We're confronted with a patient with neurologic symptoms. So I think because of the way this is discussed in the literature, that sometimes kind of alters our thinking process. And rather than thinking of an undiagnosed patient with a constellation of symptoms that might fit a syndrome, we think of these as, oh, this antibody causes that. And it's kind of a false thinking because many of these antibodies can cause a variety of symptomatologies. So I just like to really remind people that when you're trying to diagnose a patient, which is the hardest part of this, you want to think of these things as neurologic syndromes, constellations of symptoms that kind of often have this typical history to them, and then leading up to, okay, am I going to send and test for these antibodies to confirm my diagnosis? And the list of antibodies is expanding and expanding and expanding to a point where, and many of them are extremely rare, so you might have never seen them. But I think if you keep this mindset of paraneoplastic syndromes as certain syndromes and constellations of symptoms, rather than thinking this antibody causes that, I think it really can help your diagnostic clinical skills a little more than the way that we often read and learn about these disorders. And the list goes on and on. It is worth thinking of these antibodies as the intracellular versus the extracellular or surface membrane. It's not a perfect relationship, but in general, the extracellular membrane cell surface antibody syndromes, many of them are more likely to respond to treatment, but there are exceptions to that, like amphiphysin and the stiff person syndromes that are intracellular. Usually you don't know someone has cancer, or at least in a third of cases you don't, but it can be helpful when movement disorders, I think, are kind of, to me, some of the most challenging. We used to say, oh, none of the movement disorders are never paraneoplastic. It turns out they can be, but they're quite rare. When they do, they often fit certain things. But when people start having what really seems like a pure movement disorder, like a Parkinsonian syndrome, to me, that's a lot more common from the antiemetics. So people can get tardive dyskinesia from the antiemetics that we use for cancer treatment and chemotherapy, and we use them like crazy. And then certain common chemotherapies can really cause acute or subacute onset of Parkinsonian and other cerebellar syndromes, cytarabine, isosfosfamide. 5-FU is another classic one. So when you see like kind of a pure movement disorder, especially that has Parkinsonian features, I'm really thinking more of antiemetic tardive dyskinesias, or I really want to start thinking, what chemotherapies have they gotten? What is their cumulative dose exposure? Because some of these, it's really when they've been on it for quite some time. It's not an early thing. So movement disorders can be particularly challenging. And also cancer patients tend to be older. So sometimes it's true unrelated that people are getting Parkinson's or diffuse Lewy body, and it's just unrelated to their cancer or its treatment. There's been a lot of great data that I find really helpful about paraneoplastic and autoimmune epilepsies. And I think, again, too, this is several large centers pooling their data and working together to give us a better picture that can help for diagnosis and treatment of these disorders. This is kind of a slightly simplified chart, but there's certain syndromes that really have a significant incidence of new onset epilepsy. TPO antibodies are really nonspecific. I often use them as more of a screener for autoimmune tendency than for actual than for a specific diagnosis, kind of the same as many of us think of ANA antibodies. GAD65 can be challenging because low titer false positives are very common. People with type 1 diabetes usually will have GAD65, so the test alone can be misleading or false positive or not helpful. But when you have a medium to high titer antibody, especially if it's in the CSF, and it matches one of the syndromes, then I think it's incredibly helpful and easy to get. So GAD65 antibody can be associated with a pure cerebellar syndrome. It can be associated with stiff person syndrome, but it certainly can be associated with pretty refractory temporal lobe epilepsy. They'll often have a lot of deja vu, which many temporal lobe epileptics have, but the deja vu part of this epilepsy is extremely common. And it's just not that rare, and it responds pretty well to treatment. So I think recognizing that GAD65 can be false positive, but there's 3 different syndromes, neurologic syndromes it's associated with. It's not rare. It is treatable, is kind of an important point to me, I think. And some of these patients will evolve. So some of these patients I've known for years, they initially presented with temporal lobe epilepsy, and then years later, they start having a cerebellar syndrome. So it can evolve within the same patient over the years. And I don't think anyone has really come up with a reason for why that would be. The voltage-gated potassium channel antibody syndromes, I think I'm very old school, and I think of them as a group and not as the most common 2 distinct diagnoses. 10% of these patients will have new onset epilepsy, sometimes quite refractory. They'll have a lot of myokymia, and then they won't all have faciobrachial dystonic seizures, but if you have a patient having those seizures, you must test for this antibody because you just don't see that epilepsy phenomenon commonly in other conditions. And then with NMDA, they'll often have these oral dyskinesias or faciobrachial. Again, not all of them have it, not all of them have seizures, but when you see those, the first thing you should think is, I better look for this antibody because this patient might have it. And then the other one that is pretty rare, I've only seen 2 cases that I can recall, but PERM, progressive encephalopathic refractory myoclonic seizures with glycine receptor antibodies, and those can be associated with thymomas. So I think a lot of our epilepsy colleagues have gotten to know these patients, and a few have done really helpful studies showing that there's certain factors that really predict the presence of antibodies: mesial temporal lobe changes on MRI, new onset refractory epilepsy in an adult with status, a viral prodrome, autonomic dysfunction, the distinct syndromes, neuropsych changes, CSF elevated oligoclonal bands or IgG index. So if you use these factors to screen who should I send antibodies on and when am I wasting my time, it really helps increase your yield and not be sending this expensive screening test on patients who don't need it. But the more of these factors you have, the more likely it is that there's an underlying antibody. And the references for that are below, which I found really helpful. There's also kind of a score-based one that uses many of the same factors, but adds a couple. And when you add up the different points, and the reference is also down there at the bottom, it really helps decide, okay, how suspicious should I be? Should I be sending the screening test or not? And factors that predict epilepsy response to immunotherapy are the cell surface antibodies, the oral dyskinesias or faciobrachial dystonic seizures, autonomic dysfunction, and ideally you do want to treat sooner. So, that's the challenge is sometimes these tests take like months to come back, or you're meeting these people after a second or third consult. But once you suspect it, you really want to think about treating this disorder to kind of head things off. So various treatments for these. This is where things I think get really controversial because it's not like we have head-to-head trials on this saying, oh, this is better than that. But I think they're all should cross your mind and are kind of on the table and fair to think of. High-dose methylprednisolone certainly makes sense. In multiple sclerosis patients, there are studies showing that PO equivalent is just as effective. I'm not sure if I trust that for this. But it might be a valid approach. IVIG is very tempting because it's generally extremely safe. It is extremely expensive to get. I would say, in my opinion, IVIG is helpful for some of these disorders like voltage-gated potassium, but not in others. I have a lot of colleagues who use it for NMDA receptor encephalitis, and I've just never really thought it was super helpful. I am a big fan of plasma exchange, despite its inconvenience and its risks. But for plasma exchange, what I like about it is that you really have multiple mechanisms of action. You're decreasing antibodies, you're decreasing T cells, and you're really cleaning out a lot of inflammatory cytokines. So I'm a big fan of plasmapheresis and plasma exchange. Usually I found my blood bank colleagues really helpful with that. I think the one patient population it can be challenging for is people with a lot of autonomic dysfunction. A lot of them won't tolerate the full dose exchanges. Rituximab can be really useful for some of these patients. I don't use cyclophosphamide much anymore, frankly, but I know other people are big proponents of it. But I think the challenge for a lot of us is that we want these patients to get better. Some of them are very sick and very impaired, but for a lot of these disorders, improvement is not rapid, for myasthenic syndromes, for voltage-gated potassium, for GFAP. But for NMDA patients, we know the biology. The receptors on the brain surface have literally been stripped. So giving more IVIG or giving Cytoxan is not going to make them regrow any faster. So I think it's, again, where you really want to think about, what is this syndrome? How likely is it to improve with treatment? And what is the time course? Because for some of these disorders, improvement can be really rapid, like the voltage-gated potassium channels and GFAP. For things like NMDA, yes, they improve, but the pace is very slow. It takes many months because you're literally waiting for the receptors to regrow on the surface and pick up their signaling. So I think kind of assaulting these people when they're vulnerable with Cytoxan and things with risks, you just want to remind yourself of what is the normal pace of recovery for this specific syndrome and from this starting point, and not overtreat and put people at risk of infections or complications. And I think for a lot of these people, especially the younger women, you want to really discuss things like sterility, and Cytoxan can definitely make someone sterile. So you only want to do it if you really need to do it, and not just because you're inpatient for the patient to get better and you feel a need to do something that's not going to actually make them better faster. So I think, again, that's where it's good to know and reach out and be able to talk to colleagues. How quickly should this patient improve? A lot of the epilepsy colleagues too, I found they have a patient like this, they've been treated, but often you will have secondary mesial temporal sclerosis. So people will continue to have seizures because now you have a structural lesion. And most of the time, a recurrence of seizures is not a recurrence of inflammation that requires immunotherapy, but it's kind of an understudied topic. Like, should we be retreating these people or not? So for tumor screening, to kind of follow up that prior discussion, so this is kind of what some people have proposed, and I think is reasonable, but to really say, when do I not need to do screening? When, is screening risk high? Like Q, NMDA, and MA are really high risk. These are people you want to screen everything and then repeat it once a year, because it's unlikely that you won't find cancer at some point in those patients. But I think the thing that gets skipped over in a lot of the literature is that for every one of these patients, you should be thinking, well, what cancer screening should this patient have had for their age and risk factors completely separate from this? Because it's not as often that I see people getting sent for their mammograms, their colonoscopies, or for their derm exam for whole skin checks. I did forget to include, so I wrote a review for Continuum last fall. I think it came out in, I should know this, December, October? I can't remember. But if you look at Continuum, I wrote a review. And what I tried to do with that one is, there's plenty of reviews that go with these antibody tables and say, oh, this antibody does this and that. I tried to write it the way we encounter these patients, as what is the symptomatology, what is the clinical syndrome, and then what workup should I do? So if any of you are interested, that's available if you're an AAN member or through Continuum. But I would say, if there's one take-home message I would leave, is, if you're thinking of paraneoplastic disorders, please think of your treatable, reversible mimics. Thiamine deficiency, medication-induced, atypical infections, but thiamine is just, it's so common, and people miss it all the time. And it's really such a shame, because it's cheap, safe, and easy to treat. There's just never a reason not to.